Today, we are going to discuss about the examination of the hip. First of all, we have to examine the gait. In gait, the common gait is the Trendelenburg gait. Trendelenburg gait, you have to check the shoulder from the back. The shoulder is going down regularly. Okay, now I will show you. So the shoulder is going down regularly. It is the Trendelenburg gait. Antalgic gait. In walking, there are two types of the phase. One is the swing phase. And then stance, swing, stance, swing, stance. In this way, there are swing phase and stance phase are alternating. So in antalgic gait, stance phase is short. So this is the antalgic gait. And then another type is the high stepping gait. You already know. High stepping gait, you see, to clear the foot drop. So this is the high stepping gait. Shuffling gait, the foot is shuffling on the ground. In this way, this is the shuffling gait. Another thing is the hemiplegic gait. Hemiplegic gait is the, as you know, in medical work. Hemiplegic gait. So these are the common gaits, common abnormal gaits. The local examination in inspection while the patient is standing. You have to check the patients from the front, from the side, and from the back. You have to check. What will you check? As you know, 3S, scar, sinus, and swelling, wasting, deformity, erythema, and so on. In hip, you have to check the gluteal region for wasting. Regarding to the wasting, you have to check the gluteal region. Okay, in knee, regarding to the wasting, you have to check on the quadricep muscles. You have to check the quadricep muscles. This is the main thing, sir. So, in hip, gluteal wasting, you have to check. If you examine the knee, you have to check the quadricep muscles. For the Trendelenburg test, you must know about the principle of the Trendelenburg test. Here, in standing position, there is an extensor mechanisms. You must know the phases. One is the force, two is the fulcrum, and lever arm. Force means the abductor mechanism muscles, abductor muscles. And then fulcrum is the hip joint. Lever arm is the neck of the femur. Okay, to stand properly, this mechanism, abductor mechanism must be stable. So now you see, the disease side is right side. So you stand on the left lower limb. So the pelvis on the right side, there is no support, and pelvis wants to go down. But this descent of pelvis is controlled by the abductor mechanisms from the left side. So this abductor mechanism contracted, and this one cannot go down. So lumbar spine is straight. Okay, if you stand on the disease side, you lift up the normal leg. So the pelvis on the normal leg wants to go down. At that time, the abductor mechanisms from the right side wants try to control the descent of the pelvis. In this time, the abductor mechanism is disrupted because fulcrum operate, but here, for example, liver arm, one of the abductor mechanism is disrupted, so it cannot control the pelvis going down. So pelvis down, this normal abdominal side, disease side, cannot control the pelvis going down, so the pelvis will go down. So, but body want to make a trick. So he want to make a trick. He don't want the pelvis going down. What he will do? His body sway, deviating towards the disease side. So his lumbar spine is like this, deviating to the disease side. Disease side is right side. Disease side is right side. Trendelenburg test can be done two versions. One is from the back, another is from the front. So now I'm showing the back version. So disease side is on the right side. So ask the patient to stand on the normal side, sound side. Firstly, ask the patient to lift the disease side first. Yes. Now, you see the gluteal fold. You see the gluteal fold. Gluteal folds are equal. Yes. Okay. So the body can be balanced. Okay. Now, he will stand on the disease side, and then he will lift the normal side. Now you lift the normal side. So the pelvis wants to go down on the left side, normal side. Pelvis wants to go down, and then these abdominal mechanisms from the disease side control the pelvis, but fail. So pelvis go down. Yes. Okay. Pelvis go down, and then pelvis go down, but the body don't want the pelvis going down, so he will trick. So he sway the body to the normal side again. So he lifts the pelvis. Okay. So ask the patient to place his hand on my examiner's hand. Then, disease side is the right side, disease side is the right side, normal side is the left side. So, firstly, he stand on the normal side, and disease side was lift up. So, there is no pressure, because he can control the body. There is no pressure on my hand. Then after that, he will stand on the disease side, and he lift the normal side. Now, here the pelvis is going down. So abdominal side cannot control abductor mechanisms from the abdominal side cannot control the pelvis. So the pelvis is going down. But he cannot. But he doesn't want to go down. So he will control his body he control his body. He trick the body, and then he sway to the abdominal side. So the pressure on my hand is more marked. So the pressure on the disease site is marked in my hand. Okay? Examination in the sitting position. Disease site is right side. So ask now in sitting position, we are testing the iliopsoas. So ask the patient to lift, to raise the thigh. Now normal side. Then you press it. So he is lifting the thigh against the resistance. For it means we are testing the iliopsoas muscles. Okay, disease side, lift up, then against the resistance. In this way, we can test the iliopsoas muscles. Supine position. We have to, in inspection, we have to check again. So, as already mentioned, 3S, scar, sinus, swelling, deformity, wasting, and so, etc. Okay, after that, you have to check in lower limb. You have to check the deformity. There is a external rotation. Sometimes there is a shortening in this way. You have to check the position, attitude, and shortening. These are the common deformity in the lower limb. After the inspection, you have to start the palpation. Palpation, you have to start temperature at the front, side, and back. So these are the temperature. Then after that, you have to check the bony tenderness. Bony tenderness start from the anterior superior iliac spine, symphysis pubis. So symphysis pubis, and then after that, pubic tubercle, then inguinal ligament, then the first bony point is there, anterior superior iliac spine, then iliac crest, then iliac crest, then after that, posterior superior iliac spine, then sacrum. In this way, you have to check. So, first of all, symphysis pubis, pubic tubercle, inguinal ligament, anterior superior iliac spine, iliac crest, posterior superior iliac spine, and sacrum. These are the, you have to check the bony tenderness. Then, another thing, you have to check the mid-inguinal point. Mid-inguinal point means there is a between the symphysis pubis and anterior superior iliac spine on midway. This is the midpoint, mid-inguinal point. You have to check for tenderness. Mid-inguinal point, tenderness means the fracture neck of femur. Okay, then you have to check the greater trochanter. If there is a tenderness in the greater trochanter, most commonly intertrochanteric fractures. Then after that, you have to check the gluteal region. Sometimes fracture around the hip presents with the gluteal tenderness. So in this way, you have to check the bony tenderness. Sometimes you cannot elicit the tenderness in the mid-inguinal point and greater trochanter. In this case, you have to do the decompression test. First of all, you have to do place your hand on the iliac crest. Then you press from the both sides. It is called pelvic compression test. Pelvic compression test positive. If there is a tenderness, positive. Pelvic compression test positive in pelvic fractures. Then Second stage, you have to press on the greater trochanter. Place your hand on greater trochanter and press from both sides. If there is a tenderness, yes, hip compression test is positive. So here, pelvic compression test, and here, hip compression test. Pelvic compression test positive in pelvic fractures. Hip compression test positive in hip fractures. Now, we are testing for the movement of the hip. So, before you start the movement of the hip, you have to exclude the fixed flexion deformity. Fixed flexion deformity is like this. But the patients usually trick and obliterate the fixed flexion deformity by hyperlordosis of the spine. In hyperlordosis of the spine, so you see that your hand can put under the back, under the lumbar spine. So there is a hyperlordosis. So in this case, you have to obliterate the hyperlordosis of the lumbar spine. How? You ask the patient, flex the both knee. So now the patient hyperlordosis is obliterated. You cannot put your hand under the back, under the lumbar spine. Now hyperlordosis is obliterated. To maintain this position, ask the patient to hold the normal leg, to fold the normal leg. Then after that, you ask the patient slowly extend the abnormal leg. Slowly extend the abnormal leg. Now, this is the most extension. This is the maximum extension of the hip on the left hip. So now, you see there is a flexion deformity. So now you can measure. This is a 0 degree, and now flexion deformity is 30 degree. In this way, you have to elicit the flexion deformity. So this is called Thomas test. Is it already about the fixed flexion deformity? So now you have to test the flexion. We want only the hip movement. We don't want the pelvis movement. So we control the pelvis with your hand, with your hand span or with your forearm. If the hand span is small, it is not wide enough for the anterior superior spine. Actually, if your hand span can reach the both anterior superior spine, okay, you will use the hand span. If you cannot use the hand span, you have to use your forearm. You have to place your forearm on the anterior superior spine. If you have enough hand span, your hand span must be placed on the anterior superior spine. Now, I cannot do the hand span, so I will use my forearm over the anterior superior spine. Then, now starting from the 30 degree, now ask the patient or passive or active. Passively, now you move, you flex the hip. Now this is the maximum. So this is a 30 to 90 degree. So his ratio of flexion is starting from 30 to 90 degree. That's all. If you do further flexion, the pelvis is moved. I don't want the pelvis movement. This is the maximum. So this flexion, ratio of the flexion is 30 to 90. Okay, on the normal side. Normal side, you move it. Now starting from 0, move. Yes, you can move up to 10, 100 degree. if you do further flexion, the pelvis rotated in my hand. I don't want. So the maximum is 100. So range of movement is, range of flexion is 0 to 100. Okay. The same. You place your forearm on the anterior suplex spine, starting from the normal side. So if it down, so now this is the maximum. If I do further abduction, the pelvis moved. No, I don't want. Here, and then after that, you flex the knee, and then after that, here, you flex the knee and hook at the side of the back. So this is the 0 right side. Now the normal side 0 to 45 range. So now abduction on the disease side. Slowly, then you control the pelvis the same. Then here, that's all. This is the maximum. If I do further abduction, here pelvis movement. So maximum is only here, only about 30 degrees. So range of the abduction 0 to 30 degrees. The same. Place your forearm over the anterior suplex spine. Normal side 0. Here going abduction 15 degrees. Further abduction, there is a movement of the hip, movement of the pelvis. No, I don't want. So just hip movement. So 0 to 15 degrees is the abduction on the normal side. On the disease side, here 0 to here only 5 degrees. Then if further the pelvis is moved, if further abduction, there is a pelvis is moved. I don't want. So this is the range of the abduction is 0 to 5 degrees only on the disease side. Now rotation and flexion of the knee. Rotation and flexion of the hip and knee. Here, this is a lever. There is a lever. So you can see the rotation. So then after that, here you rotate. Here the leg is rotated internally, but in the hip rotated externally. So this is called external rotation. External rotation. Then here neutral. Then here this is neutral. The lever arm is now externally rotated, but the hip is internally rotated. So for the hip, this is the internal rotation. For the hip, this is the external rotation. So in normal side, 0 to external rotation, 0 to 45. In normal side, internal rotation 0 to 15. So you have to check the disease side. Now this is a neutral position. Internal rotation 0 to roundabout limited 0 to 5 degrees only. Here external rotation 0 to here 30 degrees, for example. So now this is an external rotation, normal 0 to 45. External rotation on normal side 45, 0 to 45. Internal rotation on normal side 0 to 50. In abdominal side, here external rotation 0 to round about 30, 0 here only limited 0 to 10 degrees. So external rotation 0 to 30, internal rotation 0 to 10 limited. So on measurement, before the measurement, you have to start with marking. marking 7 areas. So umbilicus, no need to mark. Then anterior superior spine. Here, starting from how to identify the anterior superior spine. Firstly, you have to palpate the inguinal ligament. Inguinal ligament, then going up, and here, first bony point. Going up, first bony point. This is the, here, after the first bony point, this is the anterior superior spine. The same on the opposite side, inguinal ligament, then you feel the first bony point. This is the anterior superior iliac spine. So this is the anterior superior spine. Second, joint line. Joint line, you flex the knee joint, and then from the upper part of the tibia, you feel it, there is a dimple here. So this indentation, you have to mark. This is the joint line, knee joint line. The same on the other side, on this side. Here, flex the knee, and then you feel the upper part of the tibia, then you mark it. This is a knee joint line. Then, medial malleolus, tip of the medial malleolus. Not medial malleolus, tip of the medial malleolus. So, here, starting from from the foot, then you feel there is a first bony point. Starting from the foot, then you feel the first bony point. So, this is the tip of the medial malleolus. So here, the same, you start from the hollow of the foot area, then after that, hollow of the ankle, then you goes upward, then you feel the first bony point. This is the tip of the medial malleolus. In this way, you have to mark first. So there's a 7 markings area. Medial malleolus, knee joint line, anterior superior spine, and umbilicus. Firstly, you have to do the apparent length. Apparent length is from umbilicus to the medial malleolus. You don't need to change the patient position. You leave as it is. So then, from the umbilicus to the medial malleolus, measurement must be with centimeter. Then you have to measure in this way. So, for example, the disease side is, left side. Now, I measure 104. Here, on normal side, 106. So, apparent length 104, and on the left side, 104. On the right side, 106. Okay, note down. Then, you have to do the real length. Before you do the real length, you must adjust the patient's position. Patient long axis of the body. Long axis of the body must be along the long axis of the bed. Long axis of the bed. Long axis of the body must be long axis of the bed. Okay, then transverse axis. Transverse axis is the line between the anterior superior spine. The line, transverse line of the patient. Transverse line of the patient must be parallel to the end of the bed. Must be parallel to the end of the bed. Then, third point is the anterior superior spine must be from, you have to check from the side. You have to check from the side. here from anterior superior spine must be in horizontal, so not be up and down, not be in seesaw position. So anterior superior spine must be horizontal. These 3 points. Say again, long axis of the body along the long axis of the bed. Transverse axis means the line connecting between the anterior superior spine is parallel to the end of the bed. Then level here, anterior superior spine, level of the anterior superior spine must be in horizontal, not be in seesaw, must be in the horizontal. It is called pelvic squaring. Second is the limb position. You must adjust the limb position. Disease side is the left side. For example, disease side is like this, maybe external rotation. So disease side is like this, maybe in the external rotation. So the normal side must follow the disease side. So you have to adjust the normal side as like the same position as the abnormal side. So the normal side follow the abnormal side. So you have to adjust the lower limb. So it is called the limb symmetry. So before the real length measurement, you must adjust 1. Pelvic squaring, 2. Limb symmetry. You must do these 2 things. After that, you can measure. So you measure, firstly you have to measure from anterior superior spine to medial malleolus. Normal side here 82. Normal side 82. Here abdominal side from anterior superior spine to the medial malleolus 80. So the real length on normal side 82 and abdominal side 80. You have to note down. After that, you have to measure the parts by parts. For example, from anterior spine to the knee joint line. Now there is a 52. Then knee joint line to the medial malleolus is, for example, 42. 52, 42. ASIS2, knee joint line 52, knee joint line to medial malleolus 42. Then on the disease side, ASIS2, knee joint line 50, knee joint line to medial malleolus 42. ASIS2, knee joint line 50, knee joint line to medial malleolus 42. Okay, note down. Left side is disease side, right side is the normal side. So on apparent length, right side 106, left side 104. So in real length, right side 82 from ASIS to medial malleolus 82, left side ASIS to medial malleolus 80. So parts by parts, ASIS to knee joint line 52. Here ASIS to knee joint line 50. Knee joint line to medial malleolus 42. Both sides the same, 42. So, here according to the chart, according to the diagram, here left side, the below knee to medial malleolus are the same. It means that the disease part is not between the knee joint line and medial malleolus, not in this part. So here is the shortening. Here is the shortening. So the disease part is in between the ASIS to knee joint line. So here there's you have to differentiate two things. From ASIS to greater trochanter. Greater trochanter to knee joint line. You have to differentiate. Now there's a shortening above the knee. So in above the knee, you have to differentiate again between the above the greater trochanter or below the greater trochanter. You have to differentiate. Which method? By Bryan's triangle, you have to differentiate. Yes. How to draw the Bryan's triangle? Firstly, from ASIS, you draw a vertical line. You draw a vertical line. Then, like this. Then, from greater trochanter, you draw along the femur. You draw a line along the femur. So there is an intersection point. So you have to measurement. You have to measure between the intersection point and tip of the greater trochanter. Intersection point and tip of the greater trochanter. Here left side is now maybe 3 centimeters, for example, maybe 3 centimeters. Okay, I will tell you again. From anterior superior spine, you draw a vertical line. You draw a vertical line. From greater trochanter, you draw a horizontal line. You draw a line along the femur, a horizontal line. So, in this way, so there is an intersection point is here. You have to measure between the intersection point and the tip of the greater trochanter. Here, round about 3 centimeters on the disease side. Okay? Yes, Bryan's triangle have to do on the both sides. Now, you already done on the disease side. Here, 3 centimeters. Then you did on the normal side. Vertical line, the same. Vertical line from the anterior superior spine and horizontal line from the greater trochanter. There is an intersection point. You have to measure between the intersection point and greater tip of the greater trochanter. So on the right side, normal side is, for example, 5 centimeters. So now you according to the C, here this part is on the left side, this part is 3. This part is on the right side, this part is 5. So now you see the shortening is above the greater trochanter. According to the Bryan's triangle, now you know shortening is above the greater trochanter. So you can exclude the lesion below the greater trochanter. From the rear end, now you suspect the shortening is above the knee joint line. Again, with the Bryan's triangle, by doing the Bryan's triangle, now you know the fracture is, the shortening is in the Bryant's triangle. Bryant's triangle level is shortened. So, if the Bryant's triangle is shortened, these are the possible diagnoses. These are the possible diagnoses. Bryant's triangle is shortened. Fracture neck of femur, intertrochanteric fractures, acetabular fractures, hip dislocation, and subtrochanteric fractures also. Because subtrochanteric fractures, in subtrochanteric fractures, after the fracture, the greater trochanter is overriding due to the pull of the iliopsoas and pull of the external rotators. The gluteus medius, gluteus minimus, iliopsoas, they pull the proximal fragment. So greater trochanter is going up. So Bryant's triangle is also shortened in this case. So Bryant's triangle is shortened in fracture neck of femur, intertrochanteric fracture, acetabular fracture, hip dislocation, and subtrochanteric fractures. Bryant's triangle is not affected in fracture mid-shaft, supracondylar fractures. Okay, in this way. So, and then in this way you can differentiate. In prone position, you have to check the gluteal muscles wasting. As I told you, hip problem presented with in hip problem, you can detect the gluteal wasting. Okay, after that, you can check the hamstring muscles power. So, ask the patient to flex the knee against the resistance. So, one hand you use for the resistance, the other hand feel on the hamstring muscles. In this way, you can check the hamstring muscles power. So, okay, flexion of the knee against the resistance. Okay, in this way, you can check the hamstring muscles power. Okay, the last one is the movement. Is that we haven't tested the hip extension. Now, in prone position, you can test the hip extension. Okay, actively. Okay, extension hip going up. Going up. So extension hip. This is the extension hip. In this way, in prone position, in supine position, you cannot check the extension. In prone position, you can check the hip extension. Okay, that's all.